Hello all, thank you for joining our webinar today. We will just let many attendees filter in, both for this virtual element and also in the room in New York where this meeting is happening, and we'll be starting in a couple of minutes. For those of you who would like to avail yourself of the interpretation function today, you can find the instructions here. I'm sure many of you have done this before, but for those of you who haven't, this is where the interpretation button can be found, and the entirety of today's webinar will be translated in both French and Spanish. So I'll let you all get that set up for those of you who need it, and we will be live from New York in just a couple of minutes. For those who have only just joined us, just to let you know, we're running a couple of minutes behind in New York as we filter all of the audience into the room. Please bear with us. We will be starting in a couple of minutes. Thank you for joining us. All the virtual attendees will be starting in just a minute. In the meantime, if you would like the interpretation function for today's meeting, you can follow these instructions. And I believe we will be ready from New York in just a minute. Hello all, thank you for your patience. The meeting is about to begin. Don't worry, your connections are not broken. We have just had a bit of a delay getting people into the room in New York, but we should be ready to go in any second now.
Yeah, okay, good morning everybody, and I'm really sorry for the delayed start. Welcome to Reimagining Approaches to Beating NCDs and Liver Cancer. Thank you so much for joining us. I have a little bit of housekeeping to do first, so bear with me. Welcome to everybody online. So this is, we have a webinar live streaming at the same time. For those of you online, there are translation which is available. Sure, everyone's got that on the slide. There will be an opportunity to ask questions if you're online to ask questions. Just put the questions in the chat box, and then Alexandra will be passing them forward to the room. Thank you, everybody in the room. Great to see you all. So we have a couple of presentations to set the scenes, and then we have we have some amazing speakers coming to speak, and then we can do a bit of Q&A, so a bit more of an interactive session. But I just wanted to start by saying thank you to AstraZeneca, because without that, we wouldn't be able to have this joint meeting, to have this meeting today. And I guess I was thinking this morning as I was walking down that we're living in a time which is all about separation. And this is the opposite. This is about integration. You know, and I think that what we know is that, you know, there's over 300 million people living with viral hepatitis. Over 1 million are dying from liver cancer, and chronic viral hepatitis is its leading cause. So we are really excited to share that the United Nations has included hepatitis testing, treatment and vaccination in the first draft political declaration, which I think hopefully many of you all know, of the UN high-level meeting on NCDs. It's the first time that the UN has referenced hepatitis testing and treatment as cancer prevention. Personally, I think it's a no-brainer. It's about the integration. It's a huge thank you to all our partners, including Gavi and UICC, who supported this vital advocacy. And I think we've got a slide with the actual written. Oh, I'm so sorry. I was waiting for somebody else to do it. I had the clicker. There's the thank yous. And this is what's actually written in, which is actually written. Just in case, I don't know, I'm presuming everybody knows who the World Hepatitis Alliance is. If you don't, just very quickly, we are a, my brain's gone empty, who are we? We are a group, I lost my words.
International.
Sorry, an international network. I'm so sorry. Very human. We're an international network of patient organisations and civil society organisations, over 400, working across, I think it's nearly 140 countries now, all in the fight to see the elimination of viral hepatitis by 2030. So with that, I'm just going to stop waffling in case I lose any more words. It gives me great pleasure to introduce Jessica Hicks, who is the Senior Director at the World Hepatitis Alliance, and she's going to be setting the scene just between the links between viral hepatitis and liver cancer. So over to you, Jess.
Thanks, Rachel. So I'm really pleased to be here today to be setting the scene. You know, globally, more than 300 million people are living with viral hepatitis. And it is one of the leading causes of liver cancer cases. But despite the scale of the problem and the fact that it is a leading cause, the links between the two are very rarely discussed. And you know, every day more than 2,000 people die from liver cancer, but yet liver cancer is not often high on the cancer agenda. Up to 1 in 4 people living with hepatitis B could develop liver cancer. And critically, hepatitis delta doubles the risk of liver cancer for people living with hepatitis B. People living with hepatitis C is 17 times more likely to develop liver cancer. And hepatitis B increases the risk of liver cancer compared by 1,020%, and for hepatitis C, 1,280%. And if you compare that to the risk of developing lung cancer from smoking, it's 600%. So it goes to show that it's highly oncogenic, but that the link has really not been well understood in the same way that smoking and lung cancer have. So the data is really startling. As I've said, awareness is low, and despite the fact that we have all of the tools that we need to eliminate viral hepatitis and therefore prevent liver cancer, these interventions are not reaching those that need them. And so this is, and more critically, it's impacting people's lives every single day. And really, that's why we're here. I think it's important to remember that behind all of these huge stats I've just said, there are people who are living with hepatitis B who are at risk of liver cancer. And this is actually our previous board member for the African region. And I just want to share this story because I think it really gives a really important insight into what it's like to be living with the disease. I was physically, morally, and financially devastated. I was exhausted by repeated checkups, examinations, and treatment with side effects. I was suffocating from taking out 2 loans in addition to the sale of my house and personal vehicle to cover my medical expenses. I was the victim of stigmatization in the workplace. So I think, you know, throughout the week, like, this is why we're here. It's to save lives. And so our white paper was developed to try and help address some of this. It was really a partnership between the Alliance and a number of different stakeholders, both in the hepatitis and cancer spaces, and critically with people with lived experience. They were at the heart of the drafting of this white paper. And the white paper includes a number of calls to action, which we believe, if implemented, will be transformative for people living with hepatitis. And so the main call to action, if you remember nothing else from today, please take this home, that we need to integrate hepatitis testing, treatment, and vaccination into funded national cancer programs to decrease the incidence of liver cancer, increase early diagnosis, and reduce mortality. But under this broad recommendation, we have a number of calls to action for the different intervention areas that we feel are most critical to drive forward change. So firstly, around awareness. As again, another previous board member, RPS, you know, he points out everyone knows what cancer is about, like what that cancer is, but no one's aware that the links between liver cancer and hepatitis. And this is supported by some data that we found, survey that we did, that found that nearly half of people globally are not aware that viral hepatitis is the leading cause of liver cancer. And so to address this, we really want to see national awareness campaigns rolled out that increase uptake of services, including testing, treatment, and vaccination. Speaking of vaccination, hepatitis B, which I think is especially critical right now, hepatitis B was the world's first cancer preventative vaccine. It's been adopted in strategies and policies, and we were, as Rachel pointed out, we're delighted to see it in the political declaration, but gaps in implementation persist, especially around the hepatitis B birth dose. Where only 45% of newborns globally receive that, and in Africa, that's less than 20%. And so it's great to have Gavi with us on the panel later, and we can dive into that a little bit more then. The impact of not having access to hepatitis B vaccination is really huge. And, you know, this is a story from Leanne, who found out that she was living with hepatitis B when she was applying for a scholarship. And this is the impact it had on her mother, who had tried to get her the vaccine and wasn't able to. And so this isn't just a disease that impacts the person that's living with it, but it impacts the whole family. And I think, again, you know, this just goes to show the human at the heart of this. So our calls to action: to expand timely access to birth dose, and also to integrate hepatitis B vaccination for children and adults into immunization schedules and cancer control strategies. Testing. You know, early diagnosis for viral hepatitis can ensure people are linked to treatment, and it decreases their risk of developing liver cancer, because the earlier that they're linked into treatment, the more likely they are to be on treatment, which decreases their risk of cancer. But yet only 13.4% of people living with hepatitis B and 36% of people living with hepatitis C have been diagnosed globally. So what we are calling for, and this is because there's a lack of robust programs and limited capacity in many countries. So we're calling for integrated, costed testing for viral hepatitis into national cancer and NCD prevention programs, and an increase of training for healthcare professionals we've seen that healthcare professionals, a lack of knowledge amongst healthcare professionals is often a barrier. And so this is a really critical part, not just for testing, but also treatment and vaccination. And to take testing to the community, we need to meet people where they are. We saw those really low diagnosis rates, and in part that is because it's being siloed at the very top of the tertiary care. And so we need to go out to the community and work with community groups to make this happen. Hepatitis treatment is cancer prevention. Cannot say that strongly enough. Yeah, only 2.6% of people living with hepatitis B and 20% of people with hepatitis C globally are receiving treatment as of 2022. So we need to drastically address this, and we need to include hepatitis treatment within national cancer and NCD action plans and ensure equitable, affordable, and continuous access to hepatitis treatment through expanded eligibility and offering treatment in accessible settings. Again, meeting people where they are. Monitoring and early detection, I feel, is sometimes left out of the conversation, but is incredibly critical because we know people who are living with hepatitis are at high risk. So we have a high risk cohort of people that are diagnosed and in care who are not being appropriately monitored. But if we can diagnose liver cancer at an earlier stage, people have a much greater chance of survival and have more treatment options. And so ongoing monitoring and early detection is critical. So, and we've seen the impact of this. So RPS was taking hepatitis B treatment, but was diagnosed with liver cancer. Unfortunately, he was undergoing regular monitoring. His liver cancer was detected early and he has made a full recovery. So calls to action are to expand the surveillance programs, invest in research and development of accurate and more sensitive surveillance and diagnostic methods. And critically, the point I really want to bring out here is to empower civil society organizations and peers to support monitoring programs in the same way that peers can support testing and linkage to care. And finally, all of this is not just going to save lives, it is cost effective. In many cases, it's cost saving. So there is a real, public health reason countries should invest in this. So in conclusion, we need to act now to integrate costed hepatitis services into fully funded national cancer control policies and programs, and this will reduce the burden of NCDs. And integrating hepatitis and NCD programs will make health systems stronger and more cost effective. And with concerted effort, together we can achieve this. So thank you very much.
Yeah, sorry, I'm going to ask Jess if she'd stay with me and co-chair with me. We've got another we've got a little panel discussion session now on hepatitis, an essential part of NCD and cancer control strategies and programs. So it gives me great pleasure to ask our panelists. So I've got Professor Mohammed Hassani, Anamaria, Bejar, and Louis. Yeah. Have a join us on our. Are you all right getting up? Yeah. On our Fantastic. So I'm gonna kick it off by starting with Professor Mohammed. I wonder, could you tell us a bit about Egypt's incredibly successful eliminating hepatitis? How has that impacted on the liver cancer cases?
Wonderful. Thank you very much. Yes. Have a lovely morning, and thank you very much for inviting me to this important event. And first, I would like to commend the efforts of the World Hepatitis Alliance and their significant role in raising the bar towards the global response towards hepatitis elimination. And again, Egypt's journey in the fight against hepatitis is quite lengthy, and I would spend days to tell you the story, but I'm trying to be very focused on highlighting some of the important turning points and key issues in the hepatitis elimination story in Egypt. As you know, colleagues, that Egypt was at a certain time considered the highest country in the world in terms of hepatitis C prevalence. And based on the demographic health surveillance in 2015, 7% of the Egyptian people had confirmed viremia. And if it should just to think about the absolute numbers, at that time, we had almost 5 million people in the age group from 15 to 59. And even the elder age groups has a higher prevalence for hepatitis C. And throughout this lengthy process of hepatitis elimination, as I said, we have a lot of turning points. Firstly, started in the year 2006 with the establishment of the National Committee for Control of Viral Hepatitis, which spearheaded the strategies, the establishment of the network of the viral hepatitis elimination centers, negotiating the prices with the global pharmaceutical companies, and also responsible for the training and education and capacity building of the healthcare professionals dealing with the hepatitis B and C elimination. And at that time, we succeeded to introduce for the first time the bigoted interferon and ribavirin, which was the sole therapy for hepatitis C available at that time. And through the period from 2006 to 2014, until the introduction of the old oral medications, we succeeded to treat almost 300,000 patients with the regulated interferon ribavirin regimen. And the second turning point happened in 2014 with the introduction of sofosbuvir, and we succeeded to be one of the earliest countries to introduce that regimen with 1% of its global price. This is one of the milestones that allowed us to treat the hard-to-treat cases that could not be easily treated with the past regimen of regulated interferon and ribavirin. And throughout the period from 2014 to 2016, we started to attract a lot of cases and increase the awareness campaigns, and additionally endorse the infection and prevention control measures. And coming to the last or the third turning point, which is the introduction of the generic medications locally produced in Egypt. And this was amazingly allowed us to deploy billions of doses to all the Egyptian government rates, and allowed us to treat a couple of millions in the period from 2016 to 2018. And based on the epidemiological studies, in 2018, we started to notice the drop of the people coming to viral hepatitis treatment center to be evaluated and treated. And we assume that all the people knows the status of their infections already came, and we need to a kind of a screening campaigns to discover the people who did not know the status of their infection. And this was a trigger to initiate one of the largest hepatitis C elimination campaign and screening campaign in the world, which started in the year 2018. And throughout 7 months of the heavy work, we managed to screen almost 63 million people in the age group from 12 and above, and treated additional 2 million people suffered from confirmed viremia. And this enabled Egypt to transform itself from being the country with the highest burden for hepatitis C worldwide to be the first country achieved the Golden Age certification from the WHO on the path to elimination in October 2023. And the beauty of this story that we did not end at that point. We're continuing our efforts with the WHO to build what's called hepatitis elimination sustainability plan to ensure that everything is kept in place and we have the same momentum, the same efforts to keep the sustainability for the blood safety, injection safety, and harm reduction, diagnosis, treatment, every pillars related to hepatitis eliminations. And we continue the efforts for liver cancer. We have so far 56 surveillance center with a well geographical distribution all over the Egyptian government rates, offering every 4 months alpha-fetoprotein and ultrasound covered by state expenses. It's offered freely for people. Unfortunately, we discovered almost 250,000 patients out from the campaign, and we successfully retained 120,000 of those patients on the surveillance program. And this surveillance center was well connected with 5 centers for dynamic imaging like CT and MRI, and also 20 centers which offering the multidisciplinary teams and having the state-of-art capacities and equipped to do liver transplantation, liver sections, chemoembolization, thermal ablation, and also offering the systemic therapy for liver cancer. And this allowed us to bring down the level of mortality coming from liver cancers to almost 50% reduction compared to 2018 so far. And again, Egypt is offering a lot of experiences and to a lot of neighboring countries, and we have now extended the bridges of cooperation between different African countries. We have a biannual training schedule with the African CDC. So far, we're offering training schedules for 60 healthcare workers from different African countries, and we're supporting several countries in terms of a lot of humanitarian aids and donations for hepatitis C medications. And that we believed even before the COVID-19 with the statement of the Director General that no one is safe until everyone is safe. And we applied that to hepatitis C as well. It's applied to the COVID-19. And for that reason, Egypt is transferring its experience to the neighboring countries for the efforts of hepatitis C elimination and supporting several countries in designing and developing their strategies and supporting their programs until together we reach to the hepatitis elimination targets set by the WHO by 2030. I thank you.
Fantastic, thank you. So can I just ask you, so internally, how do you integrate non-communicable and communicable diseases? What are you doing to integrate those?
That's a very exciting question because, I have a very amazing story. When we started the screening campaign in 2018, we thought that the people would not come to the screening points. But if we just add a very simple test like random blood sugar and assessment of the blood pressure and BMI, it will be very attractive for people. And fantastically it works. I was very surprised about it. And we're building over that. We continue to integrate the non-communicable disease services within almost 6 daily practice services offered within the primary healthcare context, like the maternal and child health, the cancer screening. Now we are offering the random blood sugar testing and the glycated hemoglobin as a point of care offered at the primary healthcare level. And this has led to discovery of millions of cases of diabetes and hypertension and linking them to care through the very robust chain of referral between the primary care and secondary and tertiary level. We count on this integration model for the improvement of the non-communicable disease services offered in Egypt, because we are facing a very enormous health burden related to non-communicable disease. 6% of our mortality is coming from non-communicable disease. We have a prevalence of 15% diabetes, 30% hypertension, and almost 70% obesity. And its reflection definitely now we are witnessing after the elimination of hepatitis, we started to see younger populations came to the viral hepatitis treatment center, to the hepatology treatment centers, suffering from elevated liver enzymes, and finally discovered to have non-alcoholic fatty liver disease or steatotic liver disease. It's a kind of a paradigm shift in the disease burden. So now we are focusing on increasing the awareness and to make a kind of a task shifting for the centers of the hepatitis elimination to work in the same way. The healthcare workers to be well educated to face the coming epidemic of the non-communicable disease and non-alcoholic fatty liver disease.
Thank you. And just to remind anybody that's online, if you have any questions for Professor Mohammed, please put them into the chat. We'll come back to you later. But I'm going to hand over to you, Jess.
Great, thank you. So delighted to have Anamaria and Gavi here today. And I think now more than ever, especially while we're in the US, it's so important to be talking about vaccination. So can you tell us how Gavi supports cancer preventative vaccines?
Thank you very much, first of all, for the invitation. It's a pleasure to be here. We have been advocating with the World Hepatitis Alliance for the last few months, and I'm very pleased to see the white paper launched with very important calls for action for all of us to rally behind. Before I actually respond to that specific question, I just want to reflect on a couple of things. The first one is that the relationship, and I love your question before, the relationship between communicable diseases and non-communicable diseases is overlooked usually. So you have 8.3% of NCDs that are caused by infectious causes. And for infectious diseases, we have vaccines, not for all, but so there are different ways of prevention. And the other thing is that NCDs in general, and I'm sure it's the case as well for hepatitis, affects differently to different populations, meaning that, for instance, in cervical cancer is the fourth cause of death in women in the world. It's the first cause of death in Africa, and it is I think it's 90% of the cases are in Africa, sub-Saharan Africa. So we need to see the inequities in everything we do, including NCDs. And finally, the third point, there is a very important point for Gavi, is that although vaccines are considered the best buy, are very important tools to combat disease, vaccines need to be embedded in strategies for diseases. So when we go and work with the cervical cancer community with with the HPV vaccine, we work with them also on screening and treatment. And the example about integration that you mentioned, if you think immunization is one of the interventions in which you have more families, more times related to the health system. So in the first year of age of a child, you have 4 or 5 touch points that you really can use to work and to screen and to prevent and to give messages and to check the women's health and check it. So now coming back to your question, I just wanted to make sure that I think because we're such an kind of important but specific topic, so immunization needs to be embedded in all these elements. Is since year 2000, so since the inception of Gavi, that Gavi financed hepatitis B vaccines for countries. And until 2023, we have supported countries to immunize 761 million children. Now is a very important breakthrough happens in 2018. And thanks to the advocacy of civil society, probably some of you were part of that. Our board approved within the vaccine investment case for the next strategic period, the Hep B birth dose, which is, as you know, very, very important. Now, that was paused a little bit through the COVID pandemic, and then it came back as a priority last year, and it was officially launched this year in July. So we expect that countries are going to send applications for this important vaccine. That is more or less what you, and in the case of cervical cancer, because your question was broader, with the most impactful vaccine is the HPV vaccine, which prevents cervical cancer. And we started a revitalization journey 2 years ago when we had as target to immunize 86 million adolescent girls at the end of this year. And I'm very pleased to say that we are on track. So we have already 44 countries have introduced the vaccines, and last year we were more or less than 70 targets. This year, for instance, like Pakistan is actually introducing the vaccine as we speak. And that's, as you know, a very important intervention, which is also stigmatized because it is related to sexual and reproductive health, which is also an area in which sometimes you have detractors, but it's the most effective vaccine. And we're very lucky that, countries have responded to that, and also populations as well.
Yeah, great, thank you. And I think actually just picking up on that last point around stigma, it's such a huge barrier, both for HPV and hepatitis. Yeah. And one of the calls to action in the white paper is around awareness campaigns. And I think national awareness campaigns can be a really great tool to starting to address some of the stigma that exists. And so how do you feel that different stakeholders can work together to sort of raise awareness and educate around the links between these infectious communicable diseases and non-communicable diseases?
So that's a great question because that's action, right? I think the first thing is to learn from the past. So we have a lot of other campaigns in other health topics like HIV that have been very successful, and we need to learn what works and what didn't work. So the second thing is to work together. So to bring different people from different sectors, different walks of life, to really rally for that. And third, and very importantly, the role of communities as leads on that and civil society, because it's not in the boardrooms or in the parliaments where minds are going to be changed. On the streets, in the rural areas, and that is where you have the community health workers, you have civil society organizations working. All of that needs to design campaigns that really speak to people that will trust, and that is also sustained. That is not a campaign by definition is something that is in and out, right? But you need to think of a campaign within a communication and advocacy strategy that is longer term.
Great, thank you. I'm going to hand back to Rachel.
Yeah, thank you. And so I'm going to say you've got to keep lived experience bang in the centre there. But I'm going to move on to Eugene Wang. Perhaps would you mind sharing a bit of your story?
My story is
Your journey. Sorry, not your story. That is broad, isn't it? Perhaps your journey with living with hepatitis B.
So my speaking of my identity, I'm a patient. I'm also a physician. So I went to medical school, and for those of you actually either practice medicine or know whoever practice medicine, the overly informed patient like myself is very annoying. because they don't trust you. They're suspicious of everything you said, and they keep looking for their own things. But in my case, it's actually precisely because of this suspicion, the doubt, the perseverance actually saved my life, allow me to sit here today. So I diagnosed with Hep B from very young back in China, and for a very long time, you know, at my generation is 10%. Now it's actually vaccination is almost eradicated, but that was a very prevalent issues out there. But you know, for the most part, I don't have any things above and beyond, you know, liver function, all the things is all fine. So I do my routine visits every year. Even though when I come to the United States, I actually start to see a GI specialist. No one told me actually ever do anything about it. Until my first child was born, you know, sometimes you have a kind of different sense of purpose. So you're busy buying life insurance, looking for different ways to actually provide kind of security to meet my commitment. So I actually look at PubMed. I look for locate this world-renowned physician in Sinai. Actually run a lot of hepatitis clinical trials. I went to him. That's actually the place is actually a start on the antivirus medication. And so I don't have any difference in symptom wise, but what is notable is actually the antivirus medication is actually knock the virus load from whatever level it is to non-detectable. This is very, very quickly and has been maintained at that level. As we see the white paper, that's actually the difference between actually, it's less about whether you have hepatitis or not. It's more about the virus load. It's actually there's the exponential relationship with the cancer risk, cirrhosis risk. So if you can actually knock down the virus load, you'll be at least according to literature, I'll be the same baseline risk as a common general population. So fast forward, I was on a monitoring protocol for a number of years. Actually, in 2017. In one of the routine exam. So my alpha fetoprotein, so this is a biomarker for liver cancer shoot up. So you know, obviously a lot of very quick diagnosis, all the things. I did find a small mass in my liver. It's a stage 2 cancer, and I actually reached out to Sue, so the previous president of Hepatitis Alliance, and she recommended a few physicians. If I actually follow her recommendation, that's actually learning. You would assume that these are the most informed out there. If I follow those recommendations, I wouldn't be able to sit here today. Is I went across 4 or 5 specialists in New York City, across the Cornell Mount Sinai system. Everyone gave me a different advice. Okay. So there are people I can recommend liver transplant because transplant actually have a highest long-term survival rate. And there are doctors very suspicious of my sky-high AIP level, feel like that's a very poor marker of prognosis. So in order to preserve my quality of life, I might as well just adopt some conservative therapy. I think fortunately, at least I have some knowledge, I have some kind of professional work, and I was able to actually reach out to see how it's being done elsewhere in China, in Japan, where actually in East Asia, where this thing is a lot more prevalent, and a lot of surgeons and physicians actually have a lot more established protocols. So I end up actually finding a surgeon willing to do the precise surgery I was looking for, which is actually is 1 out of the 5 that physician that I saw in New York City, and that's actually allowed me to be able to sit here today. So in reflection, actually, there are really 2 things actually is very alarming. I think those are the things that still exist today. I can only speak in the context of here in this country. You would assume that this is the place that actually everything is Hep B and liver cancer by a very large extent is somewhat I would say the ignored disease in the United States. You know, kind of the difference. We have very awareness and screening protocol, and if you ask liver surgeons, actually they actually see declining liver cancer patient in the recent years for demand for liver for any sort of resecting or liver transplant due to hepatitis B because of vaccination. But in the United States, largely because it's relatively rare. Hep B is actually I think population is smaller than Hep C. So by and large, it's somewhat ignored disease. It's kind of stuck in the middle for medical training. You know, the hepatologist versus infectious disease. Infectious diseases have a high focus on HIV and sometimes Hep C, and very few of those actually know much about Hep B. Hepatologists also actually don't really mess with antivirus medication in general. So it's actually not very common to have someone that really can be able to tap into those fields very effectively. And number two is actually a lack of standardization of treatment guidelines, as well as both for antivirus treatment as well as for kind of any early cancer treatment. So it's still all over the place. It's very much actually rely on physicians' personal experience. And this is actually one of the things actually I find interesting. A lot of the physicians you find actually through publication. That's my first instinct. Anything I look at PubMed, look at what are the most published authors. And those that tends to be relatively young physicians in their 30, 40, and most of the experience actually accumulated from a lab, not really from clinical practice, much less from clinical practice. So that's also a very large kind of divergent. I've been having ongoing discussions with my surgeons on these issues, on what has been done, how things are evolving. You know, things are moving, but I don't think it's to the level where it's there. The antivirus treatment is actually one of the very obvious, very cost effective. You know, right now it's all generic, but very effective, very few side effects. So where for HIV, HCV, there was a clear guideline for treatment, but right now it's still lacking for hepatitis B.
So in the white paper, it calls for increased training for healthcare staff. You know, I just wonder, I mean, that's quite a journey. I'm so glad that you're here and you're all right, but that really is quite a journey. And somebody with lesser knowledge, I wonder where they would have landed if they would even have still been here. So in terms of, you know, practically, what do you think could be done to raise awareness on that link between hepatitis and cancer, and viral hepatitis and cancer?
Yeah, certainly. I think this is one of the things actually really need to start from a medical school, from training, and started from some of the kind of key training programs in these countries. Actually, all the large residence training programs. Actually, this is the place that where physicians actually most times actually establish their professional patent and habit out there. And I do think patient groups like the Hepatitis Alliance can play a much active role in guideline. And I think for any like average patient or average physician, in the absence of access of those specialized knowledge and experience, like the only place they can refer to is actually guideline.
Yeah.
And right now the guideline is not, I would say, at least hepatitis B is not actually in the best position for both treatment as well as the kind of cancer treatment standpoint. Is actually to be able to support the best outcome for patient out there. Another thing I would just say that I think there's also opportunity to be aligned with like broader efficacies. I'm actually I have a company focused on commercialization of drugs and health technology. There's it's not just liver cancer. There's a few cancer types actually common in other part of the country, which is actually considered very much ignored in the United States. One of those is actually gastric cancer. It's very high in South Korea and Japan. You have a mass screening program, but actually South Korea have highest prevalence, those are the best outcome 5-year survival, versus US actually has been by and large ignored disease, given that a relative rarity. So it's only a specialized physician limited treatment centers really have this experience actually doing those. And there's no guideline for screening for gastric cancer, even for the high-risk population for Asian immigrants. There's nothing out there. So that's actually one of the things that actually I think we can potentially look into is and to what extent we can actually align with organizations and people's common interests. The last thing is actually it's very interesting. Actually, I was put on the transplant waitlist very briefly. I spent some time studying the transplant system in the United States. Actually, the way I understand that I need to move to Florida instead of staying in New York, because in US, all the organ transplant, the wait lines defined by geography. The problem with in New York is you have good public transit, there's very limited traffic accident, and then you have a straight gun law, people don't shoot each other often. So you don't have a lot of good donors, which is very different in Florida, Texas. There's a relatively abundance of healthy liver donors out there. So another thing is actually every year in the US, there's roughly a 5,000 liver transplant every year. I know one Hep B, eradicate the demand for Hep B, other disease gonna fuel the demand. So essentially, by and large, liver transplants dictate limited by the number of donors out there anywhere in the world. Okay, so if you take the demand for viral hepatitis out of the equation, it gives more chance to people that need transplant for other causes.
Fantastic, thank you.
Yeah, so I think Rachel, you and I could ask this panel questions all morning, but I want to give everyone else in the room an opportunity to ask any questions. So please raise your hand. While you're thinking, we have had a question come in online, so I'm just going to read that. So question has come in, what are the best strategies to integrate hepatitis elimination and liver cancer prevention into broader universal health coverage and primary healthcare systems, especially in conflict-restricted or resource-limited settings? I don't know, Dr. Hassani, if you want to share some thoughts.
It's an amazing questions. Actually, you know, a lot of universities, it's insurance systems and companies actually are searching about the best buys and the most cost-effective interventions. Unfortunately, either hepatitis B and hepatitis C. Hepatitis B is totally preventable through vaccine, and hepatitis C is a totally curable disease through medicines. And again, if you are referring back to the Egyptian experience, and I would say that during the hepatitis C elimination campaign, we spent $430 billion for diagnostics and treatment and several commodities. And based on our modeling studies, the future projections that will be seen from the hepatitis elimination reach it to $7 billion till 2030. And coming again to that disease burden, either prevention of hepatitis B or treatment of hepatitis C is one of the most efficient health interventions. Now it will be very attractive to the universal health coverage leaders and policymakers in order to be totally covered. I would say it's one of the best diseases that if you just think about its inclusion and under the umbrella of the universal health coverage, it will have a very high return on investment.
Great, thank you. Anamaria, Illusion, do you want to add anything to that? You don't have to.
I think I would perhaps repeat, it's a great question, the importance of integration, you know, and coming back to immunization and really making the most of the opportunities of having families in the health services. We know that immunization is one of the backbones of primary health care, and primary health care is the backbone of URC and universal health coverage. So it's actually bringing all the opportunities that are possible to tackle.
Great.
Yeah, I would say that yes, resource issue, you know, everywhere there's always resource issue, but in the case of hepatitis, you know, both the screening and the treatment is relatively expensive compared to a lot of other things out there. So by and large is number one, the awareness is a policy priority as well as is a standardization. So to what extent actually we can learn from other programs like the HIV program and some other programs, and potentially have some piggyback on top of those programs. So form a more consistent, broader programs actually targeting multiple disease states. The infrastructure and process has been established. I think that's partly kind of low-hanging fruits.
Thank you. Danjuma, you had a hand up?
Yeah, so thank you. Good morning, everyone. So my name is Danjuma, and I'm a community advocate and former president of World Hepatitis Alliance. So my question is to the Gavi person. Is Gavi on course to continue supporting the verticals, given of the challenges with funding? Because what we get to hear in Sub-Saharan Africa is that Gavi is likely not going to continue support for the birth-based vaccines. So what is the situation there, and what are the hopes for countries within sub-Saharan Africa?
Yeah, sorry, I just have one request to repeat the question for the online. So I will repeat it if it's all right for you, Danjuma, because I think the online are struggling to hear the audience. So the question was to Anamaria, what is Gavi doing to protect the birth dose
Sustain.
and sustain the birth dose in light of maybe some of the funding, current funding cuts?
You know, that's a great question because gives me the opportunity to explain a little bit the Gavi model. So first of all, as you know, all of us in our sector are facing budget cuts, and we are not an exception. So for the next strategic period of Gavi, which will run from 2026 to 2030, the aim was to fundraise for $11.9 billion. We just fundraised for 9. So there was a recalibration exercise on by our boards in June. There are no plans to cut the hepatitis vaccine. But what is more important is that the success, I would think, of the Gavi model that really allowed us to help countries to vaccinate 1.2 billion children since 2000 is that we share the cost with governments. So there is this co-financing mechanism in which countries start, depending on your socioeconomic status. We pay the whole bill, or we pay 99% of the bill, but throughout the years, countries increase the cost share of the vaccines. And I'm very happy to say, and for some of you will be surprised, that last year in 2024, all countries paid all the co-financing in full, including countries which are going through huge hardship as Haiti and Chad, for example. So it's the sustainability. It's not never gonna depend only of a global institution with all money. It's a common cause, and governments need to go. But communities are absolutely essential for that sustainability. So thank you very much for the answer for the question.
Thank you.
Any other questions, Charles?
Thank you. I'm Charles Gore from the Medicine Festival. I just wanted to maybe follow up for a bit of clarity. I probably know this, Anamaria, but in terms of what Gavi is financing on the Hep B birth dose monovalent, my understanding is both the introduction of it and potentially for some of the least developed countries, the actual cost of the vaccine itself. But because my understanding is that up until fairly recently, the cost of the monovalent vaccine was actually below what you would ask countries to co-finance. But now, unfortunately, because the demand has been considerably less in more recent years, it's actually gone quite above that. So are you paying for both? I think it was, I think your intervention or your co-financing floor was 25 cents, if I remember rightly, and it was below 20 for the vaccine, which I now think is about 70, the latest figures I saw. So are you going to be covering, I guess my simple question is, are you going to be covering both the vaccine and its introduction?
So we're covering the introduction and
The vaccine itself, the actual product.
Yes, because we cover the product. I mean, we co-share with government depending on where they are in the financial relationship with Gavi, because every country will be in preparatory transition or accelerated transition or in the very first. So that also depends on that. And we cover that, but we also support funding for the delivery of the vaccine. In the case of this vaccine, of the costs associated with delivering the vaccine. If that is your question, the answer is yes. I cannot really very accurately answer the percentages, but the percentages don't only depend on the vaccines, depend on the countries, and which is the classification of the country in the co-financing relationship. So that's not going to be the same for every country.
Yes, please.
So beyond the vaccine, can I also add that Gavi supports the logistics, the whole chain, and a lot of countries that has been a big issue. So they supply the solar bridges and that.
Yes, so there are costs associated, I don't have the technical name for me now, that are specifically required to deliver Hep B vaccine. But Gavi also has a funding line for health system strengthening, which goes to data system, cold chain, human resources for health, etc. We just approved a new health system strengthening strategy that's going to run from next year. And our board has approved 1.2 billion to 1.5 billion only for health system strengthening. It's a decrease from the last 3 period, but it's still the money is there. So it hasn't been, put away as a single state, because it's very important. We cannot just provide vaccine, the systems, the people, there's no nothing else. So since the beginning of Gavi, that has been factored into.
Great, thank you. So I'll take one last question, even though I've been told I'm not allowed that.
My name is Tanushree Srivastava. I'm the policy visitor. I have a question for the panel. I've been enjoying this discussion. It's very interesting that we take it right from early detection right up to liver cancer, where you need comprehensive management. Do you feel we need something like a unified index or a framework that sort of separates it by pillars, saying early detection, timely diagnosis, comprehensive management, and stronger health systems? So when we have it like that, and we have indicators for it, perhaps that's what countries can look at and say, okay, this is how we are going to not just sort of evaluate later how we're performing, but start sort of planning the entire health system and our program starting from there until the end of that. So do you think that's something that would help? Because we feel that in cancers, that is something that is needed. For example, there's something like that happening in breast cancer right now. That what has really gained traction globally. So perhaps this is something that I would love to hear your thoughts on.
Well, I will say that, if you see the 360 view of the story of the hepatitis burden worldwide, it's not the idea of just detecting certain cases and link them to treatment, because it's the final destination, I would say. But earlier to that, should have a kind of awareness about the risk factors, the transmission methods, enhancing the IBC measures within the hospitals and primary health care, also endorsing injection safety practices and blood safety. And this is actually where the essential pillars of the hepatitis C elimination guidelines released by WHO and updated several times. It spoke a lot about the prevention and awareness firstly, and then having the diagnosis and treatment at the end of the way. So again, encouraging countries to adopt the infection prevention and control strategies, especially the lower middle income countries, would be maybe cost saving than searching finally with the people having hepatitis B and C and offering them, for example, diagnosis and treatment, enhancing the prevention of hepatitis B through vaccination, and endorsing the first dose vaccine, and encouraging all the countries to adopt that first dose vaccine strategies, and maybe initiated several years from WHO. But so far, if you see the map on the global level, you will find some countries so far did not adopt this policy till now because of some financial constraints and something like that. So again, raising awareness and endorsing the prevention and inserting that prevention in the philosophy of different healthcare system would be much better than finding people and then trying to offer medications for them and exploring the way how can we offering them diagnostic commodities and offering them the proper treatment, and finally managing the complications which actually devastating and cost a lot. That's awesome.
Thank you. So I know there are another couple of questions online, but I actually think that our next panel is perfectly placed to answer those. So I'll hand it over to Rachel to close.
So I just want to say thank you very much. I think we could have sat here with just the three of you, but that's not to say that the next panel's not important as well. But I appreciate we've run over slightly, so thank you so much for your time. And thank you for co-chairing with me. So I hope you guys. Okay, so I'm now actually we're going to shift across slightly. We're going to talk about the patient charter to improve care for hepatocellular carcinoma. I'm going to give some great pleasure to hand over to Carrie James, who's CEO of the World Hepatitis Alliance.
Thanks so much, Rachel. Thank you everyone for turning out today. And it's really a pleasure to talk about this patient charter for HCC. So I think in hepatitis, we kind of talk about a lot about being forgotten and overlooked, and in a lot of ways, liver cancer is the same way. I mean, I went to a major cancer congress last year, and there was not one session. I mean, there's 10,000, 20,000 people there, like hundreds of sessions, not one on liver cancer, not one. So I think we're in a similar situation. So I think in the same way that we, talk about the importance of drawing attention to the rights of people living with hepatitis, also people that are affected by HCC are also very important. And I think that's really where this charter came out. So we were on the advisory committee that helped develop this along with other cancer organizations, other hepatitis organizations. It was chaired by the International Liver Cancer Movement and supported by AstraZeneca, which we're very grateful for. And so why did we need the charter? Because liver cancer is the sixth most common cancer worldwide, and HCC is the most common type. But despite this, like we said, it's been historically under prioritized and often overshadowed. And the patient charter was co-developed with multidisciplinary team, different organizations, and we had our face-to-face meeting in ESMO last year. And then there'll be another meeting at ESMO this year to launch it officially at the Congress. So the charter is based on these 7 principles. So I will just kind of go through these, although my eyesight might not allow me to read them. So number 1 is patients need liver cancer to be prioritized by policymakers and addressed in national strategies. This must include HCC prevention through the elimination of viral hepatitis as a public health threat. So obviously we were thrilled that with the group, felt that hepatitis should be actually enshrined into the principles as the leading cause of liver cancer, as we said. And one of the conversations we had was, the first right of someone who's affected by HCC is actually not actually to develop HCC to the point that you're going to need treatment. And that can be done by monitoring people with hepatitis so they can identify the precancerous cells and start treatment early. So I think that's, obviously very, very important. Number 2, patients need timely access to an early and accurate diagnosis and assessment of their HCC. Number 3, patients need access to a multidisciplinary team to provide comprehensive care, considering both liver conditions and cancer. And we've talked a lot about this, not only including clinicians, but also peer navigators, making sure they have the support that they need for people who have had the same experience as they've been having. Number 5. Oh, sorry. Number 4. Patients need personalized care, which considers their unique needs and preferences, taking into account personal milestones and treatment goals. Again, this whole idea of kind of personalized approach to health, that we're not just dealing with a specific disease or, we're dealing with the individual and each individual is different. Number 5, patients need shared decision-making to be recognized and implemented during their treatment pathway. I think we heard, very clearly in the first session that patients should be empowered to make their own decisions, and sometimes, the patient's decisions may not be the most obvious to the clinician, but may be the best ones for them. Number 6, patients need early access to early detection, services, care, and treatment without being stigmatized. And again, we talked about not only, hepatitis stigmatized, but I think most liver conditions or conditions related to the liver, there can be an uncomfortableness about that. There can be a feeling of judgment from that patients here feel from clinicians. So it's really important that we provide an environment that's not stigmatizing, and we don't rely on peer navigators that have to, compensate for maybe what's not a very empowering environment. And number 7, and finally, patients need a commitment to increased funding and further research for HCC, because we know that the treatments for HCC, there's some great ones coming through on the pipeline, but if you have an HCC diagnosis, it's very serious, and a lot of people don't survive this. So we desperately need more research, more treatments, so we can really increase those survival rates, for those people that even do develop HCC. Great, so that's the charter. That's going to be the frame for our next panel. So please, there's a QR code there. You can scan the QR code and download it yourself. And it's going to be launched, next month at the ESMO conference. It's available online now. Yeah, great. Okay, that's the set. Thank you.
Well, I think, Carrie, you're going to stay here and co-chair this session
Yes.
with me, yeah? So it's been a great pleasure to introduce our next panelist, where we're going to be discussing mobilising civil society and communities to fight hepatitis, NCDs and cancer together. So it gives me a great pleasure to invite Danjuma, Ileana and Dr. Zaina. Yeah,
Great.
perfect. Oh, you like this, fantastic. Brilliant. Comments. That's quite handy. I didn't tell you these today.
We can sit, we can have that chair sit in here. More chat. Hi.
Okay. So it gives me pleasure, first of all. I didn't do this on the last panel, but I made this presumption that everybody introduced themselves. And I did want to say something, because you said earlier, previous president, so I took over from you. But you listed off that you're also now an ambassador, so I wanted to make sure that was included. Yeah, so I've got the first question.
Yes.
So could you please share a bit about your experience working in civil society at CFID, Taraba? Yes, and Chagro.
So thanks, Rachel, and thanks, colleagues. Good morning. Danjuma is my name. So I think I'm super excited that this meeting is holding. And to start with, I started my local charity as an individual diagnosed with hepatitis B in 2004. And I started my local charity in 2009. And with the objective of doing raising awareness and then ensuring that patients have access to care. And as an individual with hepatitis B, I've always lived with the fear of developing liver cancer. So my local charity actually provides awareness question. And we are the first to see those patients most often. And we hear the stories of the patients. And unfortunately, most of those patients don't even end up in hospitals. And that's the sad reality. So as a community-based group, we, in fact, now currently we're developing the patient registry of hepatitis in Nigeria. We started since last year. And from 2010 to date, in our head office, and across the 10 states we're operating, we provide free hepatitis screening to patients, and then we provide also free vaccination to patients. And most often, these are services that are not provided by government, because in Nigeria, there's no government-funded hepatitis testing. So we bridge the gap, provide the services that are not provided by government, and then we are in the community where patients will always come back and need more information, and patients will always come back to need more clarification. So the good thing again is I would like to say that we are empowered patient group, because we're empowered by knowledge and by learning to understand the basics, just the basic sciences of the hepatitis, so as to bridge this gap of this information, rather than patients, because my region of Africa, most often patients rely on alternative therapy. And then Dr. Google also, and now Dr. ChatGPT provides all the information to patients. So, and again, a lot of times patients will mix the scientific language to, for example, one of the symptoms of hepatitis occurs in jaundice. So they call it yellow fever. And so naturally they want to treat yellow fever. And then, so some of those intersection between the dialect. So the essence is that as a community group, we really tease down the scientific information to patients and make them really empowered, give them the knowledge, give them the skills, and navigate them through some of the difficult health systems. They go to the hospital. Rachel, the previous guidance of hepatitis B, to be honest, shall I say, disenfranchised so many patients from treatment, and so many people did not return to the hospitals. They go to alternative care. So for the past 2 years, in fact, from the launch of the hepatitis B guidelines, we launched a relink program to bring back all the patients that previously were not eligible for treatment. And it's shocking, Rachel, that some of them we call, the relatives will pick the phone and like, why are you calling now? He has passed on. Yeah. And so it's really heart touching. Again, in my local office, Rachel, every month I receive 2 or 3 patients with liver cancer. Because we do free consultations. We have doctors, we have nurses, almost every month. And the prognosis is most of them don't live more than 2 months. With advanced tumors, advanced cases, they don't live. Just 2 weeks before I came, I was in Nairobi before I came over here. I looked at, so this 31-year-old gentleman who was diagnosed just less than 3 years ago, and he was in the hospital treated for malaria, typhoid, ulcer in a tertiary hospital. And when he came to our place to see our clinician, he already had advanced tumor and too late. And the last time I called him before coming over here, he's already almost gone. They don't survive more than 2 months, maximum 2 months or 3 months, and they're gone. And most of them young people at the prime of their age, people that have just gotten a job, like this gentleman, Matthew, he just got a job, the only son to the parents, and unfortunately, he might not live for the next 3 months. So as a community group, we have the burden of, we have the call lines where patients call in, and it's really, I mean, it's sometimes heart touching to hear the stories of those patients, the stories of pregnant women who are screened for hepatitis B and they don't know how to tell their spouses in a very religious and cultural community where, for example, polygamous families, and then the other wives will not need to know the status. So it's a very difficult, challenging scenario, but we have, I'm happy that we have my local organization, we have like 23 full-time staff, we have counselors that address some of those concerns, the misinformation, guiding patients. So we do both, I mean, the testing, the linkage to care. And unfortunately, the recent cut in funding hit us really badly because we relied on the HIV systems for navigation, for peer navigation in the hospitals, and all systems are not over there. But we're pushing and pushing to the last mile. Hopefully, we'll just get there to eliminate hepatitis.
Yeah, I suppose in the patient charter, it talks about, it emphasises the importance of the patients needing the early access, like you're talking about. But what do you do to break down some of the barriers when we're talking about stigma? And I think you referred to, kind of alternative therapies. So what do you do to change that, to shift that?
The first thing is that the information, right? Because a lot of times, most of these things are fueled by the misinformation and the feeling of guilt, the feeling of judgment. And like I said, in the cultural community, religious cultural communities where maybe polygamous home, the spouse, the partner is diagnosed, will not want to let the other person know. So we try to really do a lot of those awareness. But one thing again, in addition to stigma, is the toxicity of the financial barriers to care. And that is a big challenge majority of our patients experience. And Rachel, I want to say this, please, I don't want people to misunderstand the statement that I think over the years, we have probably overflowed the low-hanging fruits, leaving out the fruits that are off the tree. Yes, in terms of vaccination and care. Yes, it's scalable. Yes, it's result-driven to prevent hepatitis, but we have made it such that programs have neglected testing and care for people already living with hepatitis. And that is something I think we need to balance in the context of equity, because we've given governments the low-hanging fruit. All the fruits have been plucked. Please, can we go up a bit? I'm diagnosed with hepatitis B. And many people with hepatitis B have not even been diagnosed, so I don't even have the care. So the toxic healthcare system, the toxicity in terms of financial, care, and I'm in Nigeria where sometimes the patient will come and to do viral load of 30,000 naira, which is about $20. You tell you I better go and buy a bag of corn. I better go and feed my family. I better go and pay my children's school fees, because how much is the salary? And so these are challenges, stigma, the cost of care. And again, because HCC, the surveillance now, the care, the treatment, it's something that is beyond the income of majority of our patients. And so it's something I feel that we need really aggressive, just like we've been very aggressive in promoting the low-hanging fruit vaccination, we need to really be aggressive in promoting testing and treatment, because that is not being done. So my call is that the low-hanging fruits have all been plucked. Please, can we climb up the trees to get the people that have been paid to get diagnosed and treated? Yeah.
Thank you.
Great. Okay, so Elliot, I'll just introduce you briefly to begin with. So you're the Director of International Advocacy and Engagement at the Global Health Council, and also an advisory board member of the Civil Society Engagement Mechanism for UHC 2030, and the civil society board member for the Global Goals.
Right.
which I was as well.
Right.
Yes, and that's where I met Anamaria as well. So we're all old UHC 2030. Veterans and current ones, and young, vibrant UHC 2030 representatives. Yes, so, I mean, I think the patient charter talks a lot about personalized care and shared decision-making. So how can social participation be embedded in the decision-making processes to ensure that, you know, liver cancer care meets the needs of people living with hepatitis?
Great. Thank you for inviting me and for letting me be here, part of this great panel. And I feel like my job is easy because so many of my colleagues next to me and in the earlier panel answered a lot of, or provided a lot of concrete examples of how this is done. But, you know, needless to say, it's incredibly important to make sure that civil society and communities are engaged throughout all stages. So from informational campaigns, educating people, to testing, to treatment, and then to monitoring and evaluation. The reason why social participation right now is so important is because there actually was a World Health Assembly social participation resolution that was passed 2 World Health Assemblies ago. Sorry, I lost track of the WHO numbers. But countries committed to engaging civil society and communities. And now more than ever, with all of the changes in the global health landscape, it is incredibly important to put communities at the center because so many governments and even multilateral organizations are restructuring and rethinking how they're going to approach global health and different global health initiatives. And so now is the time, I mean, my call to action, I'm starting with that, is to just make sure to push these governments to really put people and communities at the center as they rethink how they're going to be educating people about different health diseases and how they're going to, you know, testing, treating, and monitoring and evaluation. So we use the term social participation and engagement of civil society and communities a lot, but I'm going to provide a few concrete examples of how this can be done in a way that is most effective in the communities. And we already do have some country level examples of how this has been done. But first, it's making sure that you're building trust with people and with communities. And how do you do this? I mean, you get to know who they are. You get to know what their fears are. You get to know them through their own languages. You educate using their own languages. Another way is we talked about community leaders and religious leaders and the important role that they play in you know, guiding communities, and involving them at the beginning is incredibly important. You know, those are the leaders that they trust. Many of these communities don't trust the government. So if a government comes in with a really scary vaccine saying, you know, take this isn't necessarily something they'll feel comfortable doing. If it's a religious leader, or if it's someone, a leader in their community that they know and trust, that's a completely different approach. So first is just making sure that you're involving patients, communities, and their leaders, and all those people that influence to build that trust between governments and the communities. The next is sharing decision-making and clinical practice. We talk a lot about, okay, once people find out, you know, they tested positive, that is very overwhelming. And having, I think we heard from other colleagues in the former panel, you know, trying to figure out what's next in many countries, including the United States, is not necessarily easy. And it can be, a lot of information is thrown at you. So working with governments, working with providers to develop decision aids, for example, with patients, where you can use those aids to present the information in a way that they understand so that they feel empowered to make the right choices and they feel informed. And all of those aids, again, should be developed with the patients, should be developed with the communities. We talked a lot about using community health workers too. My previous colleague and in the former panel, I think that's also really important, in addition to religious leaders, but looking at the community health workers and their important role that they play. And then, you know, we talk a lot about advocacy, and it's incredibly important to support advocates, but supporting advocates that have had these firsthand experiences and these real life experiences. I find those advocates to be so brave. To be able to tell their story, that's not an easy thing, and to really empower patients to become patient advocates, and to feel like they can tell their story to maybe help another person tell their own story that can motivate another person then to go get tested and treated. So I think supporting those patient advocates, supporting people to tell their story, to kind of draw down that stigma is incredibly important. And then, of course, part of the social participation resolution alludes to supporting communities to engage with government. And part of supporting is not just providing them space to give governments inputs into policies or into how they do monitoring and evaluation, but also to fund them, to finance them, to be able to bring people from very far away communities to the table. We talk a lot about these events and how the people in this room aren't necessarily the people that we need to be engaging with and talking with, not to say that we're not important. We're all a part of a system, but a lot of the time those communities that are more left behind and those people that are having those firsthand experiences don't have the opportunities to be in these spaces to tell their stories. And so supporting, pushing governments to support that kind of engagement is incredible.
Great, thank you so much. So, I mean, you've been so involved in the universal health coverage movement. So I can't think of anyone better to ask this question to. So the question is, how can universal health coverage be a platform for delivering integrated and person-centered care for hepatitis, cancer, and NCDs?
Yeah. So another thing that, obviously I'm part of the UHC 2030 platform and I'm part of the civil society engagement mechanism of UHC 2030. So UHC for me is, incredibly important. But again, I will say now more than ever, I think UHC is important because when you have so many people pull back their finances, we tend to want to go into our silos even more. And we tend to want to protect our own disease areas. And, governments right now are saying, well, okay, if we have to prioritize something, we're just going to prioritize maternal health or HIV or, and I'm not saying that it's not important to focus on specific disease areas based on the epidemiological, map of your country. But when you focus on UHC, you're going to be benefiting various different organizations, various different disease areas. And this is why I think UHC right now is critical. Because focusing on UHC, and as Anamaria said, primary healthcare is the stepping stone to achieving UHC. So focusing on primary healthcare and UHC is incredibly important right now to make sure that we don't have any of these diseases that are eventually going to be left behind if we go into our silos. And so one of the things about UHC that I think makes it well poised to pull together these different organizations is that it encourages a lot of cross-sectoral and cross-disease communication. And when you're looking at the delivery of care, we talked a lot about overlapping diseases and making sure that people are going to their primary healthcare giver, not just for one thing, but they can get tested for multiple things. So it's a really great way to integrate various different health services into one spot, one-stop shop where people can go and get all of the care that they want. Primary healthcare is also the best way to get to the communities. So that's another reason why we in the UHC space really like to focus on that. We always say leave no one behind. And one of the best ways to leave no one behind is to really invest in primary healthcare and to get the services to the people. The people won't always be able to come to the services. So you want to make sure that you can reach the people as well. And also when you're looking at universal health coverage, you're looking at a data system that again looks across various disease areas. So again, not going into these data systems that are all siloed, which, I have seen in working in various countries, how malaria is documented a certain way, HIV is documented a certain way, and it's usually a parallel system from what the, government health information system looks like. So if you're focusing on UHC, you can develop a data or health information system that is more cross-cutting and interoperable. So I really think that, pushing for UHC is not just beneficial for hepatitis or for NCDs, but for all the other disease areas too. And I think that's why it's incredibly important to advocate for it today.
Thank you so much.
Yeah, totally agree. I do have, and I'm sure you get this all the time. It's tricky. It's really hard to do when there's no money for anything. But this is another conversation. Okay, because I want to introduce. Dr. Zainab. I don't want to say your surname. You tell me your surname. UICC. Only because I'll say it wrong, and I know that you'll say it beautifully. Thank you. Perfect. So gives me great pleasure to introduce you. Thank you for coming today. So you're from UICC, so tell me, how do you think we can centre hepatitis within cancer prevention discussions?
Okay, so thank you. Very nice conversation. A lot of what I have to say has been said, which makes my job easier. So for those who are not aware, the UICC is the Union for International Cancer Control, and it's a global organization that is made up of over 1,200 member organizations spread across the world, over 150, 70 countries. And so this is a great way to start the conversation, and more importantly, to implement the power of having so many individuals as well as organizations that have knowledge, that have experience, that have participated in country-led action is immense. And that is what the US to the table. In terms of existing policies in countries, UICC works with different governments as well as organizations to help to formulate the cancer control plan, as well as implementing these plans through all the members. And so it's important as well at the country level that we focus on what is important to the country, what cancers are there in that country. And the Cancer Planners Forum is one such forum that was brought together to understand and to give those that are involved in making these policies an opportunity. So with regards to liver cancer, obviously there have been resolutions at the World Health Assembly, which many countries have signed up to and endorsed. And it's also an opportunity that we have to be able to synergize with other endorsements, such as cervical cancer. So these are the kind of parallels that the UICC is able to draw and make sure that we center the conversation about liver cancer.
How do you think, or can I ask, how do you think we bring the communities together? So the hepatitis community and then the liver cancer community, because absolutely we talked about, we heard at the top of the day, the largest percentage of liver cancer is people affected by viral hepatitis, but there's cohorts in between of people who have nothing to do with hepatitis. So how do you think we bring communities together so that?
So the easy way is by awareness. That's the low-hanging fruit, by educating our community. We have to keep on educating. We might think that we plugged it, but you'd be surprised at the number of people that still are not aware, especially within the healthcare system. And some of the practices that still go on are really horrendous, where you go to rural areas and you find things like needles are being used without, in this day and age, practices that should be abolished. So those kind of practices, we need more awareness about them. And also stigma. Stigma is a very big one that we can work on. How do we overcome stigma? Social participation, having the community gatekeepers, having the leaders in the health system and beyond to enlighten and to speak openly about it. Having patients with lived experience come up. It takes a lot of courage, yes, but we do have people that are doing it at a local level where the others in the community can understand. And to borrow from your point, it's really time, and we do need to look at how we can, because we talk about awareness and then they come, and how do we get them to do the tests, or they test, how do we get the treatment for them? That is a very big issue that needs to, it's not at all treating hepatitis and even before you get to the cancer stage. So or even diagnosing it, It's very, very expensive, and most of the people that come from low middle income countries can't afford it. So centralizing access in plans is another advocacy that we need to take seriously and look into how we can do it. In Nigeria, there's a cancer health fund that operates from 7 tertiary institutions. It covers breast, cervical, and prostate cancer. There's a lot of advocacy going on to include childhood cancer, but almost zero for liver cancer.
And is that in an action, is that the Nigerian government's action plan? Is it an action plan or is
To
it
include liver cancer? No,
any cancer?
there is, it's already established, there's a fund.
It's just a
That's
fund, but no
indigent-
plan.
No,
It's an existing.
it's an existing fund, yes,
Okay.
that you can access from 7 tertiary units, and it works. So, but there's no liver cancer covered, and there's no even diagnosis covered. I would like to know where you diagnose that for 30,000 naira. In my part of Nigeria, it's about 8.
I think Danjuma wants
Yeah,
to jump
so,
in here. I think you can have a conversation.
So I'm super happy to have Adda here because she has been phenomenal in cancer space in Nigeria. Now that she's living at UICC, Adda, one of the reasons is because you barely could see 2 or 3 liver cancer survivors.
Yeah.
So that now has limited our visibility to be in the cancer space. So, and that is one of the issues I think we've had. Jess was on the call, we had a call with NICRAD over the past 2 years. NICRAD is the Nigerian Cancer Research Institute. Over the past 2-3 years, as when I was president of the lecture, we engaged them proactively. And they now are doing a mass liver cancer prevention program. So the challenge has always been, in fact, when I heard about the cancer fund, no liver cancer, because you have breast cancer survivors, cervical cancer survivors, but you don't have, barely. In Africa, we don't have up to 2 or 3. Ibrahima, probably just a few. So that really has limited our visibility in the cancer network. So that is why I'm super happy that the WHO has established this partnership with UICC. So my call would be for cancer groups, established cancer groups, to look at hepatitis groups as potential partners, because you can't see liver cancer survivors group. It's not easy to get that. So hepatitis B organizations should be part of liver cancer networks. And that way, hepatitis screening comes in, and then HCC surveillance comes in.
Look, we're doing it in the UK, we're already doing it. So we've got people with lived experience working hepatitis, working with liver surveillance. I mean, I think it marries together brilliantly.
If I may just add one thing, just in the context of social participation, a lot of the times when we think of social participation, it's how can we get, government to talk to the communities. But it's also important for the communities to talk and educate government. And I say this because it is incredibly important right now in this day and age that we're in, to really educate governments as to, what the gaps are, what currently is not being financed that should be part of like a primary healthcare package or essential healthcare package. And part of what Global Health Council does, where I work, is we do a lot of advocacy to Congress, which, as you can imagine right now, our advocacy has changed significantly. And there's a lot of education that needs to happen because a lot of advocates in our space assume that this information is readily available and, picked up by, congressmen and governments. And you would be so surprised at the lack of knowledge that they have around so many of these issues, and they're the policymakers. So when we think of social participation, it's not a one-way street, it goes both ways.
100%.
I'll add a little bit to that. For our Cancer Health Fund to come to life, we had to go to our own Congress, the legislators. We've been pushing it for years and talking to government right up to the presidency, but it didn't get to be a reality until the legislators were involved. So really involving, getting champions, having advocates in the lawmakers, very important. They are in charge of the budget, what goes where, how they are appropriated. And when they have an interest, it's usually much easier to get done. So aside from thinking of patients with hepatitis or liver cancer, which we don't have many of, the legislators, policymakers, legislators in particular is a good place to start. With cervical cancer, there are not many survivors either of the African continent. However, it has been able to get that gravitas that liver cancer hasn't. Why? A lot of things.
I guess with everything that you're saying, what's really important, and that takes us back to the beginning, it's really important that we, all of us, are working together. Because the message then that goes out to policymakers is stronger and louder. I'm really conscious that people are going because we're running out of time.
Yeah, we're running a bit late.
Yeah, I think the questions online, am I right to say they've already been answered?
There's a bunch of questions online, but
I think we've answered them.
yeah, I think a lot of them have been covered. I don't know if anyone in the room has any last minute questions to stay through. Otherwise, please come up and feel free to have a chat with the panelists afterwards.
But one last word, 1 minute, not 10 minutes. But one last, what would you like to leave the room with? What's your final around patient charter?
The patients in Africa should be, people with hepatitis B should be diagnosed more to prevent liver cancer.
Fantastic.
I think look at the person and not the disease. Don't just look at the liver, look at the person as a whole.
Yeah.
Have organizations involved in the whole process and have them, integrate, look at how we can integrate existing facilities and care pathways to what we're trying to achieve.
Fantastic, Carrie?
No, I think it's been an incredible panel. It's been an incredible session. Just big thanks to everybody who's come here in person in New York and everybody that's online. I think it's been a really important session, and thank you all very much.
Thank you.
Thank you.